Hi, I'm Dr. David Robertson, and this is Immunology 101, Part 1, also known as Understanding the CBC or War is Hell, because there's a lot of military analogies used in discussing the immune system. I am a partner of Allergy Immunology Associates in New England. I have no financial conflicts of interest, and I will not be discussing off-label use of medications. The goals of this talk are to develop a better understanding of basic and practical immunology, be able to identify the most significant areas in which immune dysfunction may occur, and to make Margot, who originally followed this talk, she had a talk on primary immune deficiencies. So this is kind of a lead-in to that. So as doctors, we see CBCs with diffs all the time, right? So this patient, you can see something happened on February 5th where their white blood cell count went up, and they have some actually fairly persistent eosinophilia. But, so we're like, oh, eosinophils, that's maybe worms. We're kind of taught these patterns, right, when we were in med school. So neutrophil elevations are associated with bacterial infections, lymphocyte elevations are associated with viral infections, but at least when I was a med student, I didn't have a good grasp for why that was, or kind of what was actually going on there. So today we're actually going to talk about the immune system and maybe develop a better understanding of how to interpret that differential that you look at all the time. So the innate immune system is composed of conceptually two overriding parts. The first part being the innate immune system. The innate immune system is as good as it's ever going to get when you're born. It never gets smarter, it never learns, and that is in contrast to the adaptive immune system. When you're born, the adaptive immune system is essentially non-existent, except what you've temporarily borrowed from your mother in the form of antibodies passed through the placenta and maybe through breast milk. So today we're going to focus on the innate immune system. The innate immune system is good at pattern recognition. So these are generally things that either are not contained in the human body, so they're external things, or they're signs of damage, or they're kind of warning signals. So the first one are PAMPs, which are pathogen-associated molecular patterns. And the second one are DAMPs, or damage-associated molecular patterns. So these are the two things that the innate immune system is very good at recognizing. If there's a molecule that doesn't fall into one of these categories, it's a little something more sophisticated, it's not going to be picked up by the innate immune system without help, possibly from the adaptive immune system. So there are two kind of main components to the innate immune system. There's both cellular and acellular components. So first we're going to talk about the different cellular components. So when you think about your CBC with diff, some cells, actually the majority of cells you see on that, are actually associated with the innate immune system. So the predominant cells of the innate immune system are the neutrophils. And then you often also see monocytes, which actually monocytes are immature macrophages. And for some reason, I never really conceptually grasped that when I was a med student or even in residency. But monocytes mature into macrophages. Macrophages are long to write, and they're screwing up the spacing of my slides, so I'm going to abbreviate that with the Greek phi for phage, which is sometimes how you'll see them abbreviated in immunology texts. Then there's eosinophils, right, which we already kind of touched on in our original CBC. And then there are basophils, right? So those are the guys on your differential diagnosis. Because I'm an allergist, as well as a clinical immunologist, I also spend a lot of time talking about mast cells. So if you look at the breakdown of these cell types, by percentage, neutrophils play, by far, are the largest percentage or largest population of white blood cells that you have, actually of any kind, but specifically in terms of the innate immune system, by just a huge margin. So everything else is kind of minor. Interestingly, you'll notice that you never see mast cells on your differential, and we'll talk about why that is in a second. So altogether, the cells in the immune system account for about 65% of your white blood cells altogether. So let's talk about neutrophils because they're the biggest deal. So neutrophils are kind of the infantry, starting this military analogy. They're grunts. They go out, they actively engage in combat, or they actively attack things, and they're expendable. They're not particularly smart or sophisticated. They just go out, they recognize these PAMPs or DAMPs, attack things by releasing granules, right? Because these are actually the majority of these are granulocytes, so they have preformed granules that they release, so they're ready to go. So here is your neutrophil rolling around your blood vessel wall. And this is called loose or rolling adhesion. So it's pushed along with the flow of blood in your blood vessels, and it's stuck to the walls, right? And so it is marginalized. So it's around the margins of your blood vessels and also in your bone marrow. You have a significant portion of neutrophils hanging out in your bone marrow. So those things that it's latched onto are called integrins. And so what's supposed to happen is these neutrophils just kind of roll along, and then when they come to a site where there's an infection or there is damage of some kind, they actually stop and they adhere to that area. And then they transmigrate. So what happens is you get upregulation of local binding proteins. And so you go from loose or rolling adhesion to tight adhesion. And then it's just stuck there, and it then gets signals, and the gaps actually, right, the hemidesmosomes open up, and you get transmigration of the neutrophils actually down into tissue. And so that's how it's supposed to work. So a couple things to know about neutrophil adhesion. One, integrins are very, very steroid sensitive. They're kind of like a fern that closes up if you touch it. So as soon as steroid touches integrins, they actually change their shape and they close up. And so all of a sudden, neutrophils can't bind to the integrins, and so you get demarginalization. So this is why you have a relative neutrophilia when you treat somebody with steroids. It's not because your body has suddenly made a bunch more neutrophils in response to steroids. It's that the neutrophils that you had, which are primarily at the periphery of your blood vessels and bone marrow, are now demarginalized, so they're floating around in your blood. The other thing, right, so you guys have probably heard of, there's a clinical vignette. There's a baby with delayed detachment of the umbilical stump. And so that's kind of a classic vignette for leukocyte adhesion defect. So in leukocyte adhesion defect, there's actually, the problem is not with neutrophil function, or production. You actually have an appropriate or maybe even elevated numbers of neutrophils. They just can't demarginalize, or they can't marginalize. They can't adhere to the vessel wall. So if they needed to get in to attack something, they can't do that. So for what it's worth, this is something that I think comes up on the pediatric boards, and there's that that classic vignette. There have been 50 to 100 cases of leukocyte adhesion defect ever reported in the literature or known in terms of the clinical immunology community. There's actually two different types. I've never seen it. You will probably never see it. And there's actually active discussion about what does that mean? What is delayed detachment of the umbilical stump? 6 weeks is a number that's commonly thrown out there, but it can go, I think, as long as 2 months. If you ever are rounding a newborn nursery or you're seeing a newborn for follow-up and you have this concern, the cheap and dirty trick you can do, or dirty test you can do, is just get a CBC with diff. Again, this is not a problem with neutrophil production. It's a problem with neutrophil margination. So you would expect that these babies would have significant neutrophilia because they would have a lot of white blood cells floating around in their serum that can't stick to the blood vessel walls. If you have a baby with a normal neutrophil count, basically you've ruled out leukocyte adhesion defect. Okay, so here's actually a neutrophil, and you can see maybe around it, neutrophils is a kind of larger gray blob in the middle, and to the right and actually to the left there are a pair of diplococci. So these are staphylococcus. So here's the neutrophil actually chasing one of the staph, and we'll talk about what's actually going on there in a second when we talk about complement. but ultimately it captures the staph, right? And now it's phagocytized it. So that staph is now inside the neutrophil in a phagosome. And now what's supposed to happen, right, is that the neutrophil pumps in a bunch of oxygen-free radicals in the form of either hydrogen peroxide or superoxide dismutase, and it kills that staphylococcus. If that can't happen, if that process is broken, specifically is the pump is broken to kind of get the to generate the oxygen radicals, that's chronic granulomatous disease. So what happens is these things get engulfed, but then they don't actually get killed. And in fact, they can ultimately kill the neutrophils or escape. And so this is important for skin immunity. This is important for fungal immunity. So chronic granulomatous disease is interesting because it's named for a finding that's really a side effect of the process. So what actually happens is because the innate immune system, the neutrophils aren't working properly, you get kind of auxiliary functions where the body tries to wall off the infection by forming a granuloma around it using T cells, which is not the optimal way to kill these type of bacteria. So that is chronic granulomatous disease. All right. So I think that's really all I have to say about neutrophils. So then let's actually move on and talk about monocytes or macrophages, right? So monocytes and macrophages are professional antigen-presenting cells. So they also phagocytize bacteria, but what they then do is grind up those bacteria. So the primary goal is not really to clear infections like neutrophils, which is why there's so many fewer of them, but they grind them up and then they present antigen in the form of MHC, right? So MHC is the major histocompatibility complex, and there's actually, right, there's two different kinds. So there's MHC1 and MHC2. Almost all nucleated cells have MHC1. Only professional antigen-presenting cells have MHC2, right? And these present to different kind of T cells. And a lot of times people have trouble remembering which ones go with which. So MHC1 presents antigen to CD8 cells. We're going to talk about what those are in a second, but those are kind of like the commandos or special forces. So they are similar to neutrophils in some way. They go out and actually actively engage in combat, but they're very specific. They specifically strike only certain targets, and those are the targets that are identified by MHC1. MHC2, on the other hand, binds to CD4 cells, and CD4 cells are kind of like the command center. And so the professional antigen-presenting cells, like monocytes and macrophages, and there are others, right? There are dendritic cells and other cells that are professional antigen-presenting cells. These guys really help direct the adaptive immune response by binding and presenting antigen to CD4 cells. Now, that said, I'm not actually aware of any immune deficiency that the only defect is a lack of monocytes or a defect in monocytes. And that's probably because you have other professional antigen-presenting cells that can kind of pick up the slack if that happens. A couple other things I want to say about MHC. Like I said, sometimes you'll have trouble remembering how to which MHC binds to which cell, and the answer is it's always going to multiply together to be 8. So MHC1 binds to CD8, and MHC2 binds to CD4, and those both multiply together to be 8. The last thing I want to say about MHC is MHC is actually the exact same thing as HLA, right? So HLA is human lymphocyte antigens. These are different names for the same thing. And so, right, when we talk about, or when you're studying for your board, you're like, oh, HLA-B27, which would increase risk for the ankylosing spondyloarthropathies, right? Why is that? Well, there's something about that specific mutation or genotype, I suppose, that for whatever reason, HLA-B27 is more likely to bind and present self-antigen associated with those disease processes and lead to autoimmunity. So that's the exact same thing as major histocompatibility complex. All right, so moving on to eosinophils. Eosinophils are also granulocytes, right? So they have preformed granules just like neutrophils, but their granules are a little bit different, right? So they're primarily basic. So they basically, what they do is they're very good at fighting worm infections. Um, and the way that they do that is they pour out bleach, perchlorate, um, which is good if you want to kill worms. It's bad if this is happening in other parts of your body, like in the esophagus, which you can see with eosinophilic esophagitis, or in your lungs, like with allergic asthma. And in fact, that's where, in terms of pathology, in terms of eosinophil deficiency, there's a lady at the NIH, Amy Cleon. She's a PhD, and she is generally considered the eosinophil guru in North America, maybe in the world. And she has 8 or 9 patients that appear to have congenital eosinophilia. They have no eosinophils, and they are all from first world countries, and they have no significant health problems. Maybe if you're growing up in a part of the world where you're prone to parasitic worm infections, this would be a much bigger deal. But for people with access to clean drinking water, not having eosinophils does not seem to be a significant issue. In terms of pathology, eosinophils play a much larger role in terms of causing disease, specifically allergic disease. And I think the only other thing that's important to know about eosinophils is IL-5 is the hematopoietic both growth factor and life signal. And this is a recurring theme in immunology. Cell types have something that kind of drives them to differentiate, and then also is a sustaining signal for them. And if you take away that sustaining signal, those cells go away. So for eosinophils, it's IL-5. For T cells, it's IL-2. We don't know them for all cells, but those are known. So if you have no IL-5, you have no eosinophils. And so there are now 2 medicines on the market that actually specifically target that. One is called mepolizumab, which is called Nucala, and the other is resoluzumab, which is called Sincair, and they're both now indicated for the treatment of eosinophilic asthma. They've only been out for about a year. I should say they've only been FDA approved for about a year. And I've got to say my experience with them has not been that encouraging. They've been around for a long time, and they just haven't been that effective. So you have a disease process, say like eosinophilic esophagitis. Well, that's got eosinophils in the name. So you'd think that if you gave somebody with eosinophilic esophagitis an anti-eosinophil medicine, they would be magically better. And it turns out they're not. This is another example, eosinophilic esophagitis is another example of a disease process that's named for a finding that doesn't totally encapsulate the entire pathology there. So there are other cells involved in eosinophilic esophagitis. There are T cells, there are neutrophils, there are lymphocytes, there are mast cells, and you wipe out the eosinophils, and for some patients that helps, and for others it doesn't. There's a disconnect between tissue eosinophilia and symptom scores in the context of eosinophilic esophagitis. So they've definitely looked at these medicines. The manufacturers would love to have an indication for EE or EOE because there actually is no FDA-approved treatment for eosinophilic esophagitis, but it just didn't pan out. And I think that's all I have to say about eosinophils. All right, so moving on to basophils and mast cells, right? So basophils and mast cells are both also granulocytes, and actually they secrete many of the same things. But interestingly, when you see CBC with DIF, you see basophils, they're way at the bottom. You generally ignore them. Sometimes they're high, sometimes they're low. What does that mean? I think most people probably just ignore basophils. And that's not an unreasonable thing to do because they account for a very, very small amount of both the innate immune system and your overall white blood cell counts. They're about a 1%. Mast cells, you never see mast cells on a CBC with DIF. Is that because you don't have very many mast cells? Actually, no. You probably have more mast cells than you have basophils. The difference is basophils are in circulation, whereas mast cells are tissue-bound. Both can be activated in the context of allergic disease, which again is primarily where they play a role, or they come into play, I should say. And they both secrete things like histamine. So histamine makes things red, itchy, and swollen. which we'll certainly talk about a lot when we talk about more allergic disease. The difference is there's two. One, basophils in circulation. Mast cells are tissue bound. So this is also why when I do allergy skin testing, I scratch your back to find out what's causing your asthma or your itchy nose or whether you're allergic to foods, because those mast cells should be, in theory, evenly distributed throughout your tissues with surface-bound IgE. So you should have the same mast cells in your skin as in your nose or your eyes or your GI tract. The only other thing that I would say about them is they both release histamine, but only mast cells have tryptase. So if you ever have a question of whether or not somebody's had anaphylaxis or an allergic reaction, you could check a serum tryptase. If that's elevated, that would support the idea that this was, in fact, a true allergic reaction or true anaphylaxis. The only caveat to that is in the context of food allergy, there have been documented cases of anaphylaxis where you don't have elevated tryptase, and the feeling there is that's caused by basophil activation, because the food is absorbed into the GI tract and then gets into circulation, and basophils are involved. All right, and I think that that's the cellular components of the innate immune system. So by far, neutrophils play the biggest role, probably followed by monocytes. Eosinophils, basophils, and mast cells largely play a role in pathology, and you don't really have deficiencies of those things. Well, the only other thing I'd say about mast cells is there are a couple mast cell diseases. One is mastocytosis, which is a low-level clonal myeloproliferative process where your body's actually making too many mast cells. Often this burns itself out, but sometimes it can progress to other hematologic malignancies. And then there's also something called mast cell activation disorder, which is newer and somewhat controversial. It exists, but it's often overdiagnosed by patients using Google. Mast cell activation disorder is characterized by having mast cells with a low, for reasons that are not clear, degranulation thresholds. So they're just activating inappropriately. They activate more commonly. Interestingly, you don't necessarily see an elevated tryptase with that. You do see an elevated tryptase with mastocytosis, but what you might see with mast cell activation disorder is elevated urinary histamines or something called 11-beta prostaglandin F2. Both of these diseases are associated not actually with hives, which is maybe what you would think of, but actually flushing, crampy abdominal pain, and then with the mast cell activation disorder, there's a bunch of somatic complaints like fatigue and joint pain and things like that, and that's probably why people come up with this diagnosis, searching Google for kind of somatic symptoms. All right, so let's move on to the acellular components of the immune system. So there are a few. The first is skin, and I say this not to be obvious, right? So the skin is a barrier, so it's the fundamental thing that separates self from non-self, outside from inside, and so it does that by being both a physical barrier, but there are a number of chemicals, actually antimicrobial chemicals that the skin secretes, things like calicidins, that play an active role in immune function. The other thing, two other things, if your skin barrier is disrupted, so for example, probably the most common cause of this would be eczema, right? So in the context of eczema, the primary issue is usually impaired ceramide or impaired skin oil secretion, and then the skin gets dry and cracked and red and irritated. And what happens then is you have this kind of disrupted barrier function and an inflammatory cytokine milieu, which then predisposes to allergic disease if things get in and kind of presented to the immune system in a strange way. The other thing is that in many forms of severe immune deficiency, SCID specifically, or there are some complex immunodeficiencies like Wiskott-Aldrich, where severe eczema is part of the phenotype, and that just kind of goes to the overall state of dysregulation there. But beyond that, I don't have very much to say about skin, just except to know that it is a fundamental part of the immune system. It's a physical barrier. All right, complement. Complement, is really straightforward. All you have to do is memorize this simple diagram, and you will be a master of complement. No, that's a joke. Complement I have always found somewhat confusing, and that's because I think of this kind of this lab bench nomenclature that turns people off, right? So, but complement is actually very straightforward. It only has a few functions. So there are 9 main proteins, right? And they are named C1 through C9. And then there are a few helper proteins that are probably worth knowing about, specifically for the boards. If you ever have a question about X-linked complement deficiency, that's propyridine. That's the only X-linked immunodeficiency associated, I should say, only X-linked complement deficiency. The other thing that, again, is more relevant for allergic disease or angioedema is C1 inhibitor specifically. So C1 inhibitor is the off switch. So you want complement to get activated, but you also want to be able to turn it off. And if you can't do that, that results in hereditary angioedema. So complement really only has a few functions. It complements both the innate and adaptive immune systems. And you may remember there are 3 different ways that it can be activated. One, again, this goes back to pattern recognition. It's not smart, it's not fancy. In fact, this is almost completely structural, right? One is lipopolysaccharide. So lipopolysaccharide is specific to bacteria, not humans. Human cells don't have that. So if you've got that floating around in your blood, that's bad. And so complement proteins are structured in such a way that if they come into contact with lipopolysaccharide, they activate, and that means that they change their shape, and then it starts a cascade that ultimately leads to full activation of the complement system. Likewise, mannose binding lectin, which is something that's present in fungal cells, can also activate it, and then IgG and IgM can activate it. Interestingly, there are immunoglobulins that don't bind complement. So IgA does not bind complement. IgE doesn't really bind complement. And there are some kinds of IgG. IgG4 does not bind complement. So basically it's pattern recognition of things that are warning signals in your system. Okay, so in terms of function, there's really just a few functions. So basically, complement does a few different things. One is tagging. It basically sticks to stuff that it has recognized as foreign and says to the rest of the immune system, this stuff is bad. And there's some fancy names for this, but one is opsonization, where it kind of completely coats it, and then the other one is chemotaxis. So if you remember back to that video of the neutrophil chasing around that staph aureus, how does it know to chase the staph? Well, complement does that. So basically, that staph diplococci has been tagged with complement, so the neutrophil is following a C5 gradient. So it's tracking towards complement C5 on the surface of that staph aureus. So that's how that works. And then clumping, I would actually kind of lump together with tagging. So basically, this again, complement proteins sticking to the surface of things, and then in the case of agglutination, it actually causes them to lump together, so they're easier to recognize and clear out by the immune system, the other players of the immune system. And then the last one is lysis, right? So this is the membrane attack complex, which is functionally a hole puncher. It just punches holes in cells to get rid of them and to destroy them. And so you can kind of break down complement proteins into the early phase and the late phase. So the early phase are really the ones that are more involved with tagging and clumping, and that's C1 through C5. And then the late phase, which are C6 through C9, are associated, those are the ones that cause lysis and are associated with the membrane attack complex. So that's a picture up there of Voltron. I think no one who's listening to this talk is old enough to remember Voltron, although it was recently rebooted on Netflix. I think the equivalent that you would recognize is the Power Rangers, right? So these guys all had different bots or suits or something, and they would all kind of come together to create a big, powerful Zord. Is that right? I don't know. Anyway, a big robot. And this is kind of the same way that the late complement proteins work. So they actually all link together, and it forms like a funnel-shaped thing that then punches holes in the cell surface membrane to get rid of them. So in terms of deficiency, complement deficiencies are very rare, and they're relatively severe. So if you have a C1 or C3 deficiency, this is going to present in early childhood with severe recurrent infections. C2 and C4 deficiencies are more common and more mild in terms of their phenotype. There is an association actually between these and lupus, SLE. And then in terms of the late complement proteins, I would say that the only real one is if you have a problem with them, you have increased susceptibility to intracellular infections. So the most common here is C9. And if you have a board vignette with somebody that has recurrent, meningococcus pneumonia or meningococcus meningitis, then that's kind of a clue that you should be thinking about a complement deficiency. Again, there's a cheap and dirty test you can do to evaluate the function of complement, which is just the CH50. So this is the classic pathway is what this is supposed to evaluate. So the CH50 is interesting. It's a very old school test. So basically what you do is you take a patient's serum, you spin it down, and you just get the serum because that's where all the complement proteins should be, and you actually incubate that with lamb blood. And lamb blood has proteins in it that are foreign and should activate complement. And the CH50 is how long it takes for the complement in your serum to lyse 50% of the lamb red blood cells. So it's a very old school kind of, 18th century kind of medicine thing. There's also an AH50, which is a test to look at the alternative pathway, but that's almost never done. All right, so then the last component of the acellular innate immune system are toll-like receptors, and I just have a little bit to say about them. They're kind of neat. They have this kind of, they're called a shepherd's crook, this kind of half C shape. And they can be both extracellular or intracellular. And basically, again, they are surface bound, unlike complement, which is floating around serum. They're kind of the surface bound analog to complement. So these are receptors that recognize specific foreign proteins and, again, kind of activate intracellular processes. So the extracellular ones recognize extracellular things like bacterial proteins, whereas the intracellular ones typically recognize genetic material, specifically DNA, RNA that is associated with viral infections. So specifically, there are 9 or 11 different types of toll-like receptors, depending on how you count. Some specific ones to know. TLR4 is one that recognizes lipopolysaccharide. So that's kind of analogous to the alternative complement activation pathway. Toll-like receptor 7 is interesting. So this is recognizes single-stranded RNA, right? So that's an intracellular intraendosomal
and there
toll-like receptor.
is a specific medicine, imiquimod, which is a topical agent that targets toll-like receptor 7. And what it's used for is the treatment of genital warts. And I first encountered this actually in adolescent clinic. And so HPV is not an RNA virus, it's a DNA virus, but its genetic material is single-stranded RNA. So when you paint, what you do with the imiquimod is you actually paint it on the surface of the genital warts, and it targets the replicating HPV and stops that, and causes a local inflammatory response, which then helps clear the overall genital warts. So I think that is all we need to say about toll-like receptors, and altogether that kind of concludes our look at the innate immune system. So we looked at the cellular and acellular components, and then in our next talk we'll move on to the adaptive immune system, which is primarily concerned with lymphocytes. I hope you enjoyed this talk.